A good afternoon from Abu Dhabi. Thank you, Maria, for the introduction. It's a real privilege and an honor to be here and be speaking amongst such accomplished physician leaders and researchers. And thanks for the invite and the opportunity. I'm a medical breast physician, and I serve as the director for the hereditary high risk program at the Oncology Institute at Cleveland Clinic Abu Dhabi. I also chair the primary care department. I hope you can hear me okay. Um, so I'll be talking about breast cancer genetics, screening, and prevention. I have no financial disclosures to report. I'm sorry, this is moving too fast. Um, this is Cleveland Clinic Abu Dhabi, and if you're visiting Abu Dhabi, please come and visit us. Um, I'm sorry, I don't know why this is moving so fast. This is a picture that I took of our team from the newsletter a few weeks ago, and the team is between the Cleveland Clinic, Ohio, and Abu Dhabi. So I'll take a few seconds to talk about the medical breast program, which was pioneered by Dr. Peterson in 1995. And under the medical breast program, we have three service lines. We have the hereditary high risk program, we have the survivorship program, and we have the medical breast clinic. And then in the Ohio campus, we also have the fellowship program. So here at the Abu Dhabi campus, we take care of the pathogenic gene mutations and the patients with family history of breast cancer or those who have high-risk benign lesions such as atypical hyperplasia or LCIS. These two categories go to the hereditary high-risk program. The breast cancer survivors go to the survivorship clinic, and then abnormal mammograms, benign breast disease, and symptomatic patients all go to the medical breast clinic, and they're managed in a multidisciplinary fashion. So we're just going to look at what happens when we have a BRCA pathogenic gene variant. The patient is initially counseled by the, I'm sorry, I have no idea why this is moving so fast. Um, the patient is initially counseled by the genetic counselor and then establishes care in the high risk clinic. From there onwards, because of the high risk of breast cancer, both for BRCA1 and 2, up to 70% lifetime risk, they are counseled in the surgical oncology for risk reducing mastectomy. Because of the ovarian cancer risk of up to 17% in the BRCA2 and up to 47% in BRCA1 carriers, they are counseled by gynae oncology for risk reducing salpingo-oophorectomy. These patients are then seen in the lifestyle clinic for lifestyle modifications. They're seen in dermatology clinic for the tiny risk of melanoma, and then finally in the Digestive Disease Institute to be counseled for the risk of pancreatic cancer, which is up to 7% lifetime risk. So this is just a snapshot of how we manage these pathogenic gene variants in a multidisciplinary fashion. So coming back to our talk, the objectives of the talk are to review screening guidelines for average and high risk population, to identify patients at high risk for the development of breast cancer, including those with hereditary cancer syndromes, and to select who will benefit most from preventive medication. So as you can appreciate, the pink color represents the global burden of breast cancer we face, shared in this the stats by WHO last year. Breast cancer remains the most frequently diagnosed cancer in females worldwide. The variability is huge in the prevalence globally, where it may be as high as 16% lifetime risk in certain parts of Western Europe. and as low as 6% in certain parts of Eastern Asia. We don't quite understand why, but we think environmental factors might be also contributing to this. According to the data in the US, 1 in 8 women will be diagnosed with breast cancer sometime in their life with an average risk of about 12% and median age of 62. However, this is quite different in the data here in the UAE, where breast cancer may develop a decade earlier with a median age of 52. And based on some studies, experts believe screening should be offered earlier than 40, maybe as early as 30. However, the guidelines in Department of Health here in Abu Dhabi still recommends starting screening for average risk patients at 40. So just a few minutes to talk about the breast cancer genetics. So back in 1950s, Watson and Crick shared the double helix structure of DNA where it all started. And in 1977, Sanger sequencing was introduced, which would sequence single gene, rather laborious process and quite expensive. And then 1994 was a landmark year when BRCA genes were discovered through the Sanger sequencing, both BRCA1 and 2. And over the next few years, a few other breast cancer related genes were discovered. And in early 2000s, next generation sequencing was introduced, which changed the landscape of cancer research, and multiple genes could be sequenced simultaneously in a more cost efficient and faster manner. In 2008, GINA in the US became a law, and no discrimination was allowed for the employees based on their genetic test results. In 2010, somatic tumor sequencing came about, which helped planning the cancer treatments. And then in 2013, the Supreme Court overturned the gene patency rights of Myriad Lab. Till then, it was only Myriad Lab which was doing the genetic testing. But after that, gene panel testing became quite common, and multiple other labs opened up for these molecular gene testing. And now, in recent years, polygenic risk score is under great research and is being integrated with risk estimation models in some of the labs to stratify the breast cancer risk. So this is what we know today. We have the 6 highly penetrant breast cancer genes, which may be responsible for up to 15% of breast cancers. These include the well-known BRCA1 and BRCA2. But the other four worth remembering are PALB2, TP53, PTEN, and CDH1. Amongst the moderately penetrant genes, we have the 7 genes which may be responsible for up to 8% of breast cancers. 2 worth remembering in this list are the CHEK2 and the ATM genes. And then we have the SNPs, which are single nucleotide polymorphisms, which may be responsible for up to 20% of the breast cancers. Now, these are low risk alleles, which individually may not infer much risk, but collectively as polygenic risk score might be able to stratify the breast cancer risk. And this is an article we wrote a year ago for the SWH magazine on polygenic risk score. It's available online if anyone would like to read more. This is a list of conditions which are the red flags and should trigger referral for genetic testing. So I'm going to go through the list, which includes breast cancer diagnosed under the age of 50, ovarian cancer diagnosed at any age, triple negative breast cancer, and this was added following the Olympiad trial, highlighting the role of PARP inhibitors in treatment of breast cancer. Bilateral breast cancer when diagnosed under the age of 50, male breast cancer, pancreatic cancer or metastatic prostate cancer, Ashkenazi Jewish ancestry. We know Ashkenazi Jewish ancestry have BRCA genes are more common in this particular community. In general population, is as common as 1 in 400, but in Ashkenazi, it's 1 in 40. So again, they are recommended to have genetic testing. And continuing with the list, if there are 3 or more breast cancers in a patient or the close family, or finally, any pathogenic gene mutations running in the family. And this is an exhaustive list of algorithm we use in our high-risk clinic, and I'll be happy to share this offline if anyone's interested. So let's look at the screening guidelines for our average risk patients. Now, there is a difference in opinions from the experts globally on when to start the screening and how often to do it. But there is consensus in the US amongst the American College of Obstetrics and Gynecology, American College of Radiology, and National Cancer Comprehensive Network, NCCN, to start screening at the age of 40 annually and to continue till the patient is healthy. Now, there is plenty of data out there showing that women who undergo serial mammograms, the breast cancer mortality is reduced by up to 50%. And again, these guidelines for annual screening are backed by NCCN, ACR, and also Cleveland Clinic, Abu Dhabi, and Ohio follow the same guidelines. So what about the high risk women? So high risk women are recommended to have annual MRI for their breasts, and the list includes patients with pathogenic gene variants, both highly penetrant and some of the moderately penetrant genes we saw before, or their untested first degree relatives, patients who have lifetime risk of 20% or higher, those who have had history of chest radiation under the age of 30, and then survivors, breast cancer survivors with dense breast tissue, or those who were diagnosed of breast cancer under the age of 50, and finally, ones who have atypical hyperplasia or LCIS. And we will look at why the atypical hyperplasia and LCIS are high risk. Well, this was a landmark paper which came out of the European Society earlier, suggesting or recommending MRI breast every 2 to 4 years after the age of 50 for women who have extremely dense breasts. And male breast cancer is rather uncommon with average risk of 1 in 1,000. However, the ones who have pathogenic BRCA2 gene are at high risk of up to 18% and are recommended to have annual mammograms from age 50 onwards. So let's look at the breast cancer risk factors we cannot change. Increasing age is a fact of life, and we know that breast cancer risk increases with age and peaks around mid-50s for the Arab population, and globally in mid-60s it peaks. And those who have high-risk benign lesions such as atypical hyperplasia, which comes with about 29% risk of breast cancer over a 25-year period, or LCIS, which comes with about 2% risk per year. And then patients who have pathogenic genes may have higher risk, and we've already discussed the different categories earlier. A slightly increased risk for women who have early puberty or late menopause, and again, slightly increased risk of for women who have nulliparity or older first child at an older age, particularly above the age of 35. And women who have extremely dense breasts, which is prevalent in about 10% of the population, come with fourfold risk of breast cancer compared to the fatty replaced, which is the other extreme on this side. Most women, about 80%, fit in the category of the scattered fibroglandular and the heterogeneously dense category. Let's look at the risk factors we can change. And we know that lifestyle matters. So low trans fat diet studies have shown to reduce the risk of breast cancer mortality. But we know that regular exercise, maintaining a healthy weight, and reduced alcohol consumption all reduce the risk of breast cancer. So how do we identify these high-risk patients? The guidelines from NCCN, USPSTF, which is the United States Preventive Task Force, and ASCO have helped in putting the categories of high risk and very high risk. Um, and in the high risk categories, we have first degree relatives having breast cancer under the age of 50, which comes with twofold risk: atypical hyperplasia and LCIS, already discussed, and those who have 5-year risk of 1.7% or greater using the Gale estimation risk model, those who have 20% or more lifetime risk by using either the Gale risk model or the IBIS risk model, those who have had chest irradiation under the age of 30, which comes with about 29% lifetime risk, the extreme breast density, moderately penetrant genes, and perhaps SNPs in the future will be in this category. And then the very high risk category includes the highly penetrant 6 genes we looked earlier at, and which may come with risk as high as 85%, and also the compelling family history. So let's look at who benefit most from preventive medication. Well, we target our preventive medication for patients who have atypical hyperplasia or LCIS, those who have 5-year risk of 3% or greater, those who have 10-year risk of 5% or greater, and those who have uh, genetic mutations predisposing to ER positive tumors such as BRCA2, CHEK2, ADM, CDH1, and PALB2. And let's look at why these genes are important. I'm sharing a study of about 50,000 breast cancer patients here with association with tumor pathology published in JNCI 2 years ago. This paper showed the results. And if you look at the top, we have the ATM showing predisposition to ER positive tumors shaded in the green color here. A similar result with CHEK2 showing strong predisposition to ER positive tumors. With BRCA1 showing the purple shade here, strong with showing strong predisposition to triple negative cancers. However, in the postmenopausal age, you can see a tinge of ER positive tumors showing here, while BRCA2 and PALB2 both showing enriched with ER positive cancers as well. And this study, published in JAMA Oncology earlier in the year, looked at 9 specific genes studied on 42,000 breast cancer patients and showed a similar trend where the forest plot showing BRCA1, strong predisposition to triple negative cancers, BRCA2 showing enriched with ER positive cancers, and both ATM and CHEK2 showing strongly ER positive cancers here. PALB2 quite similar to BRCA2 and showing ER positive enriched cancers, whereas BARD1, RAD51C, and D, all three showing triple negative cancers. Therefore, we focus our um, preventive medication on BRCA2, CHEK2, ADM, CDH1, PALB2, and perhaps BRCA1 over the age of 50 when first diagnosed over the age of 50. And we hesitate offering preventive medication for patients predisposing to strongly ER negative cancers. Now, the preventive medication uptake is vastly underutilized, and about 4% of the patients got into a study done in the US were on preventive medication out of the 16% eligible patients. And studies showed that the main barriers were physicians' time, education, and comfort in doing the risk assessment and offering prevention medication to these patients. Also, patients were fearful of the side effects of some of the medication, including tamoxifen, thinking these are cancer drugs. So what options do we have in our prevention therapy? So we have the four drugs, including tamoxifen and raloxifene, which are selective estrogen receptor modulators. And we have the exemestane and anastrozole, which are aromatase inhibitors. Now, tamoxifen is the only drug used in premenopausal category of patients. However, all four options are available in postmenopausal women. Both aromatase inhibitors are used off-label and not FDA approved. However, all four are used widely in our practice and are recommended by NCCN, USPSTF, and ASCO. Here is a snapshot of all the major chemoprevention trials showing up to 65% risk reduction. The NSABP1 trial looked at tamoxifen versus placebo in about 13,000 pre and postmenopausal women and showed up to 50% risk reduction. The long-term follow-up at 15 years showed this protection is maintained after completion of therapy for up to 15 years. IBIS-1 trial was a smaller study and was less well received as a number of women were on HRT prior to the study. STAR P2 trial was a head-to-head between tamoxifen and raloxifene on 20,000 postmenopausal patients and showed 50% risk reduction with both at 5 years. However, it dropped with raloxifene at 8 years down to 38%, showing superiority with tamoxifen. MAP3 trial looked at the exemestane on about 4,500 postmenopausal women and showed an impressive 65% risk reduction. Now, although the study was done over a 3-year period, we still offer 5-year therapy for our patients. IBIS-2 trial looked at anastrozole on about 4,000 postmenopausal women and showed about 50% risk reduction. A low-dose tamoxifen trial was a small Italian study done on about 500 patients, both pre and postmenopausal, and showed about 50% risk reduction. Now, this study, although a small one, is helpful for patients who are unable to tolerate the full dose of tamoxifen and can be tried on the lower dose. So really, key takeaways from today's talk are to screen average risk women annually beginning at 40 and continue till they are healthy. And for high-risk patients, annual MRI screening is recommended, and it varies, the timing varies depending on the type of the high-risk patients. For instance, for BRCA patients, it can be, or it's recommended to be started as early as 25 years of age. All women should maintain ideal body weight, exercise regularly, and limit alcohol consumption. The most important high-risk patients to identify are those at risk for hereditary cancer, and short-term risk estimates using the risk models can be used to guide recommendations for preventive medication. Thank you so much for listening, and I'll be happy to take any questions towards the end.